Hi, everyone. I'm happy to get us started. For those who don't know me, my name is Donna McKay, and I'm the Executive Director of Physicians for Human Rights, or PHR. I'm told that we have nearly 900 people registered for today's call, which is great, many of whom are frontline health professionals working to beat back the pandemic, as well as many others who are also advocates working aggressively to address the numerous inequalities that can determine in this disease who gets sick and who dies. So I really want to thank all of you for taking the time today to join us for this discussion. And before I turn it over to Dr. Ranit Mishori, I want to acknowledge all of my PHR colleagues, staff, volunteers, board leadership, and partners, and of course, our wonderful panelists today. As the COVID-19 pandemic has escalated, the expertise and the insight of PHR and our network of clinicians has been in extraordinary demand, more than any time in our history. PHR has fielded urgent nonstop requests from the media for expert analysis on the pandemic's impact on people in vulnerable situations, some of which we'll be talking about today, responded to very many requests for collaboration and consultation from our partners in the global NGO field, looking for expertise of health professionals for their legal and other policy efforts related to COVID-19. And of course, just the general public's unprecedented hunger for truthful, reliable information from a source they trust. And in addition, over the last several weeks, PHR staff and volunteer health professionals had contributed to emergency litigation in more than a dozen cases with partners on issues including immigration and customs enforcement detention, pretrial detention centers, including Rikers Island in New York and other US facilities, and intervention on behalf of specific individuals with high-risk medical issues, and those being punished for hunger strikes in protest of continued confinement. And these efforts have resulted in several recent wins and releases of affected people, with many more still pending. But as I think we all know, so much more has to be done, and it has to be done urgently. As many of you have been following at the state prison in Ohio, for example, Marion Correctional Institution, they've had at least 1,800 confirmed cases among inmates, which represents 73% of the inmates, and this does not include the staff. The spread of the virus in areas of forced confinement is absolutely horrifying and devastating. And in addition to the massive threat to health, simply this wasn't a detainee sentence, not in jails or prisons or immigration detention center. So fortunately, there are actions that can be taken, and today we have the pleasure of benefiting from the expertise of medical, human rights, legal, and correctional facility and detention center experts who are going to discuss the US and international response to the danger of contagion in these densely populated environments. So we welcome your questions throughout today's briefing. You can send questions to webinar@phr.org, which is webinar@phr.org, or you can just submit to the Q&A box, and we'll do our best to address them later in the session. So today's moderator is Dr. Ranit Mishori, PHR's Senior Medical Advisor and an incredible champion for migrant health. During the pandemic, Ranit has played a leading role in PHR's partnerships with organizations dedicated to protecting healthcare workers, detention litigation, and refugee protection. Dr. Mishori is also a professor of family medicine at the Georgetown University School of Medicine and director of the department's global health initiatives. She's a practicing family physician. And Dr. Mishori provides clinical care for refugees and asylum seekers. She documents human rights violations affecting migrants domestically and abroad, and is a guiding force on education and scholarship on these issues. So Dr. Mishori, I'm going to turn it over to you, and I'm going to exit from the panel and come back at the very end. Thank you so much.
Thank you so much, Donna. I appreciate this intro. Good afternoon, everybody. I am so heartened to see so many of you that are registered and are viewing us right now, and people who care about this topic, about these vulnerable populations, people behind bars, in jails, prisons, and detention centers, that ordinarily the public views through quite an unsympathetic eye. So thank you for being here right now. As Donna mentioned, over the past few weeks, there have been many reports from many parts of the country and the world about coronavirus outbreaks inside what we sometimes called places of confinement, affecting both those who are held in these facilities as well as members of the staff. And reports from the field are quite grim. Donna mentioned the case in Ohio, but we've heard about at least three deaths of inmates at Rikers Island in New York, where more than 365 inmates and 780 staff members tested positive. In Chicago's Cook County jails, at least 7 died, with more than 200 inmates and more than 190 staff members testing positive. 38% of the coronavirus cases in the state of Arkansas are concentrated in the state prison. And these are just a few examples of many, many more. And also we need to mention that this is in the context of very limited testing capacity. In immigration detention facilities, thankfully no cases of death reported just yet, but as of Wednesday, we've heard about more than 287 cases of coronavirus that have been confirmed. And there are also cases reported in ORR facilities where children are being held. So today, I'd like our conversation to highlight not only the situation in the US, but also internationally, and talk about responses to the threat of coronavirus outbreaks in places of detention. We have a fantastic panel, and our experts today will discuss medical and public health issues related to detention during this pandemic. They'll discuss, they'll put a human rights lens on the situation globally, and they will review how medical legal partnerships are helping release some individuals and how decisions being made today will shape the landscape of and precedent moving forward legally and medically. So I think what we're going to do right now is we'll have some opening statements from each of our panelists, and I will introduce each of them before they begin, so it's easier to kind of keep track of who's who and what they're famous for. I want to start with Dr. Scott Allen. Dr. Allen is a professor emeritus of medicine and associate dean of academic affairs at the University of California, Riverside. He is co-founder and director of the Center for Prisoner Health and Human Rights at Brown University, and serves as an expert medical advisor to PHR and has done so for many years. On March 17th, so definitely more than a month ago, he co-authored an op-ed in the Washington Post, and he was one of the first voices in the US alerting the public that rapid action to release prisoners was really critical and was very, very time sensitive. So Dr. Allen, I'll give it to you, and then we'll continue.
Thank you, Dr. Mishori, and thank you for allowing me to participate in this really excellent discussion, an opportunity for discussion at this really critical time. So I want to just make some brief opening comments to try to set the stage of what we're talking about here. You've done a wonderful job in laying out the impact. You know, when we wrote that op-ed just a short time ago, but it seems like a year ago, and when colleagues of mine and others were trying to raise the alarm early, you know, at the time, not much had happened yet. And we did sound a little bit like, you know, we were running around saying that the sky is falling. As you summarized, from the limited data we have, the kind of tinderbox scenario that we tried to raise the alarm about has started to actually unfold. For me personally, it's distressing that in the case of the Riverside County Jail System, where I'm a court-appointed monitor, they had among the earliest warning of these kinds of concerns, and yet are now seeing an outbreak involving 3.9% of the inmates being positive with limited testing, and actually, sadly, 2 officer deaths so far. So this is hitting very close to home. The concepts I want to share with you and the audience is, first of all, infectious diseases and control of infectious diseases is not at all a new concept to those of us who work in detention health. This is really a heart of the work we do, and we've, over the years, done things to mitigate and fight tuberculosis, viral hepatitis, measles, varicella or chickenpox, norovirus, many other threats. And the reason we have to be mindful of these threats is because jails, prisons, immigration detention share very high risks of rapid and efficient transmission of infections. Why is this? Sort of the obvious things. It's congregate setting, it's close living quarters. Often these facilities are overcrowded, hygiene is poor, there can be limited access to health care. The health status of the inmate population or detainee population is often poorer than that of the surrounding communities, and that's relevant in diseases like influenza or coronavirus. But last and not least, I want to make sure everyone listening understands there's also a revolving door aspect to detention facilities. I think people who don't think about this problem very often imagine jails and prisons, detention centers to be isolated, walled off, sort of quarantined areas removed from the general population. If that's what you think, then you don't understand how jails, prisons, and detention centers operate. There's actually quite a bit of churning of people coming and going. And that is a relevant concept for us to keep in mind as we talk about not only the impact on those who are incarcerated, but communities that surround these facilities as well. Now, I've already said that infectious disease is not new to correctional settings. So that we do have tools and we have a lot of experience. They are things like screening, testing, vaccination, use of isolation and quarantining, cohorting, hygiene, personal protective equipment. But we have to understand that in the case of coronavirus, as we're seeing in our communities, this is really a worst case scenario, such that these normal tools that we would use to try to prevent outbreaks or try to control or mitigate them, they are not alone sufficient. And in fact, some of them are not even on the table. We don't have vaccination. We really don't have effective screening and testing yet, although that's evolving as we speak. Quarantine and cohorting can work with less efficient viruses, but really have limited effect with a virus that's as easily spread as COVID-19. So it became obvious to those of us who work in the field early on, as we sort of all called each other and conferred, as we began to understand the dynamics and characteristics of this particular virus, that we really had to reduce populations in these centers, that these centers would become tinderboxes, if you will, not only for rapid and efficient spread among the population, but we were also mindful of that these outbreaks in facilities could quickly overwhelm local healthcare capacity. If infections rip through a facility, some percentage get sick, have to be sent outside hospital, some percentage need to be intubated and put on ventilators. You're now consuming very precious resources in the community and having impact on community health. Likewise, with the comings and goings of asymptomatic individuals, you could spread. Once there's been a flare, you've accelerated the spread of infection. So, the way I think it's important to think about this is to remember that the virus doesn't care who you are, what you are, why you are where you are. And while we all seem to mostly understand the importance of social distancing and reducing the spread, if we forget detention health, it's as if we said, we're gonna have everyone really, tank the whole economy by keeping everyone home, but there's one sector that we're gonna just give a pass. And it would be as if we said maybe bars and nightclubs could stay open. Those of us in public health know if you have a weak link in this process, that's where your spread is going to occur. And right now, that's, I think, what we're seeing. I do want to just give a shout out. This is just released from our colleagues at ACLU. It's a report out that you can Google and find with some modeling showing how the virus will not only spread through detention, but will increase the death rate in the community by a significant fold. So I think that's important for everyone to be aware of. The last comment I want to make is that there has always been a cost associated with detaining people or incarcerating people. And I'm speaking from the United States perspective, where we incarcerate and detain more than any other country in the world. There are costs to that, costs to individuals, to communities, to the public health. That's not new. What COVID has shown us, though, is that the balance in the equation has dramatically shifted. If we justify detaining people by saying we are protecting the public safety, not that I would even concede that that's always true, but if we say that, then we must accept that there is now a unique danger posed by detaining people in high numbers. So the most important message for me to share with the audience is, just as a matter of fact and as a matter of science and as a matter of public health, we really have to consider and quickly reducing the population of detention centers during this pandemic in order to keep those who are confined safe, people who work in those facilities safe, but also the community safe.
Thank you so much. I know that there are already a lot of questions that we're getting for all of you, but we'll have to be a little bit patient before we get to the questions. So next, I would like to introduce Eunice Cho. She's a senior staff attorney at the ACLU with the National Prison Project, where she focuses her work on challenging unconstitutional conditions in UN immigration detention facilities and the expansion of immigration detention. She is also leading the ACLU's litigation efforts currently around COVID-19 immigration and detention centers. Eunice, it's your turn.
Well, I just want to say thank you so much for having us here today. And we have been so grateful to Physicians for Human Rights and the contributions that PHR has made to the litigation effort that the ACLU and other organizations have been pushing around the issue of COVID-19 in immigration detention facilities, prisons, and jails. It's been an extraordinary, just a resource to have at our fingertips, a well of incredibly qualified medical professionals to be able to provide expert affidavits, declarations, and testimony about the public health implications of what happens when COVID-19 arrives in congregate settings like immigration detention facilities. And indeed, we've seen courts be very persuaded by the testimony that has been offered by medical professionals. As we all know, immigration detention, prisons, and jails, conditions in those facilities, even before COVID-19, posed a great danger to the health and safety of people who were locked up in those facilities to begin with. In immigration detention facilities, for example, we have heard complaints about lack of medical care and mental health care. That is the same in prisons and jails across the country. We've heard constant complaints about lack of sanitation and hygiene in these facilities, people saying that they would not be able to get soap, access to important things like hand sanitizer. All of these things before COVID-19 hit were issues, but have since become magnified as critical issues that in the face of a global pandemic where there is no cure, there's no vaccine or medical treatment available, and where social distancing really is the only strategy available for people to, particularly those who are particularly vulnerable to serious illness or death if infected with COVID-19. That is really the concern of much of our litigation and advocacy at this point. About a few weeks ago, about 6 weeks ago, when we started thinking about COVID-19, and as Scott had mentioned, it does feel like almost a year ago. At that point in time, we began to understand that the ramifications of COVID-19 in these types of environments, in detention environments, in prison environments, what kind of impact it would have, and it was staggering. Combined with the knowledge and information that we have based on prisoner and detainee reports and our own advocacy, our own litigation, even prior to COVID-19, we knew that this was a disaster in the making. And many advocacy efforts began in essence at that point in time. The ACLU and many partners began to immediately try to alert local prisons and jails and detention centers of the dire circumstances under which these facilities were operating, and really began to encourage local officials to come up with some plan, any plan, to try to mitigate the effects of what would happen if there was a COVID outbreak. Some agencies began to be responsive to that, and indeed there was a movement of many folks in the criminal justice system in particular to begin to consider releasing prisoners, pretrial detainees from custody to try to bring down the numbers so that overcrowding and those types of consequences would not further make the disaster in those facilities even worse. The same, unfortunately, was not true for the immigration and customs enforcement setting. As we all know, ICE is a federal agency, and it is a quite politicized agency where immigrants have regularly and consistently are demonized as part of a political platform. And so to bring up the idea of release to this particular administration was somewhat challenging. That, in essence, left the courts as one of the only options to try to urge release of immigrant detainees from custody. And indeed, this has also been the case in many other systems where release has been unfortunately inadequate to the extent that there is a clear and present danger posed for people in custody. Since in the last 6 weeks, the ACLU has brought over 30 cases to challenge the continued custody of medically vulnerable immigrant detainees around the country, as well as arguments to bring down the numbers of people held in immigration detention facilities. We've brought over 40 cases in the criminal justice context targeting jails and prisons as well. And for the most part, we have seen some helpful and hopeful gains. We've had almost 100 people on the immigration detention side released as a result of our efforts, and that is still continuing. We have many, many cases that courts are still pending court consideration, including class actions. On the prison and jail side, there have been hundreds, if not thousands, of people who have been released as a result of this litigation. But as we said, this is not enough. Some of the helpful precedent that has been laid out as a result of these court actions has been recognition of the grave public health risk that is posed by COVID-19, as well as the court's authority to be able to release people on habeas petitions because of the overwhelming conditions of confinement, where release is really the only option for people to have safety in such a time of crisis. This is a step forward in terms of the case law for sure, but even more importantly, we get back to the mantra that I think has really focused our litigation from the very beginning, which is we need to get the maximum number of people out of detention and jail in the fastest time possible to avert this public health crisis. Ranit had mentioned many numbers with respect to the dangers of COVID-19 outbreaks in correctional and detention facilities, and our fear is that absent any drastic action by authorities, that these numbers will continue to rise. And in fact, our argument is that especially for people who are medically vulnerable, especially for those who face serious illness or death, statistically proven likelihood of serious illness or death if they are to contract COVID-19, that these facilities must act quickly in identifying those who are particularly vulnerable first, release them, and also bring down the numbers more generally in these facilities. We are concerned somewhat with the transparency of numbers that is actually being reported by the government. For example, ICE, which is now a detention system that I think as of today is down to over 30,000 people in the detention system. This is down, of course, from a high of 56,000 people at one point in the Trump administration. And I think the variable in that number also goes to maybe raise the question as to the underlying purpose and the need for detention of this large number of people in the first place. But to really identify that, as of yesterday, ICE stated that there were 287 confirmed cases of COVID in 28 facilities. This is, of course, after the director of ICE's admission to Congress that they had, so far as of last week, only tested about 400 people in custody. This is less than 1% of people throughout the entire population in ICE detention. And in its public reporting, ICE is also neglecting to report the number of infections amongst third-party contractors. And this is particularly important. You will notice on the ICE website, for example, it will say they'll have confirmed cases, and 35 as of yesterday confirmed cases of ICE employees in 11 facilities. But this really does not account for the fact that 80%, as of our last count, of ICE detention beds were run by private prison companies or third-party contractors. And to account only for about 20% of the staff of facilities really begs the question as to what really is the true extent of infection among staff who are present in ICE detention facilities if it's not, if they're not people who are directly hired by ICE. These are just questions at the tip of the iceberg, and these questions are particularly important because ICE has stood up in court and said that it has that there's no impending risk to detainees because there are no confirmed cases of COVID in detention facilities. And courts, unfortunately, have bought into that logic and said, come back to us when there's a confirmed case of COVID in the facility. Now, we all know that all of our public health experts have said that is actually the wrong time to begin to start seriously thinking about releasing people from custody and depopulating. By that time, it is almost too late. Not too late in terms of people who desperately need to get out, but it certainly is emblematic of some of the lags in terms of preparation, in terms of our response to COVID-19, where we know that there could be quick measures taken to avert impending disaster. I do want to say that we are heartened by the growing wave of cases across the country that have started to understand the enormity of the situation and have urged the government to a rapid and quick action to release people from custody and also to begin to supply some of the most basic needs necessary for people to achieve social distancing and practice hygiene to the extent possible. But our underlying message is really especially for those who are medically vulnerable, this will not be enough. And we are very, very afraid of what is to come if further action is not taken in an urgent manner.
Thank you so much. And we are going to switch to something a little bit more global. We have with us, we're lucky to have him, Gerald Staberock. He is the Secretary General of the World Organization Against Torture. He's joining us from Geneva, Switzerland. He's a longtime expert on human rights and confinement and global prison conditions and monitoring. And Gerald, I'm happy to say, is part of a global group that I've recently joined of torture and human rights experts that has been working to develop a policy brief on these same very issue through a very global lens. Gerald, you can take it from here.
Thank you, Ranit. And first of all, thank you for the invitation to join this panel. I'd like to explain a little bit where we come from and how we look at the issue, but I also like to pick up on something I think that you said at the beginning about the urgency of the issue, but also the opportunities that might be in this. So just to explain a little bit more what strange animal we are so that you have a better sense of where I come from. I know that in the anti-torture world, and I'm working for an anti-torture organization, confessions are very bad, but my confession to you is I'm not a doctor, I'm a lawyer. But I have learned in my life working on torture how important it is that we have different communities coming from their angle, looking at the torture issue. And I see this very, very lively when we talk about this particular issue in question, how we need the expertise, the voice of doctors on these issues like Physicians for Human Rights to complement the more traditional human rights advocacy that organizations like ours are doing. So I'm very pleased to join you today. The way I look at this issue is from our experience working as a anti-torture network. The OMCT has a very maybe pompous name, World Organization Against Torture, but it's a small organization. But what makes it big is that it is a global network of some 200 organizations locally who address torture in their context, who monitor, who provide support, who litigate, who engage their governments, who visit prisons, etc. And we try to protect and support that global network of actors. And in that context, of course, we deal a lot with prisons, we deal a lot with detention issues, because obviously detention situations are always risk situations for torture. And the cure is transparency towards secrecy. And the whole idea of confinement is based on secrecy. So you can see how the responses that we apply to the COVID crisis can increase the risks for human rights in such a setting. Now we look at the prison system more broadly in terms of human rights, but of course, like in every crisis, people say that it reinforces and amplifies the good and the bad. And that's the way we look at a little bit at the issue of prisons and detention and COVID. Many of the issues that we will discuss are already there. They're underlying problems that now get amplified. And this is one of the opportunities I also see, that we give light to those issues and maybe can change the way people look at punishment, people look at overcrowding. I often visit places of detention. I've been in last November, I've been in Togo, where we visited places of detention. They look very different from US jails or detention centers, I assume. They look more like a market square. They are completely overcrowded. And I usually say, well, if this was a business, it would be in bankruptcy for a long time, but nobody wants to listen to this. And we see now opportunities to address this overriding issue of overcrowding, for example, because people see what consequences it can have. And this is one of my hopes also for the future in terms of the opportunities, that we will look at what punishment is, what prisons are. Usually we don't get a lot of attention to the issue. Today, I was told there are almost 800 people watching this webinar. This is absolutely amazing. I would never have thought before that we could organize something on detention condition, overcrowding, release of prisoners with that amount of people. And I think it shows the type of opportunities we have also to make an issue more seen that deserves more attention. When we look, of course, at the prison situation and COVID situation, we look at different angles. We look at a public health issue. How can we contain a public health crisis in and outside prison and detention? We look also at a security issue, not only in terms of release and what happens to people and the type of arrangements for post-release support we have to think of. But you have to understand that prisons are sometimes they are repressive systems, but they're also very fragile systems. So if you are a prisoner, everything in the environment that changes you will be on high alert. You will notice it immediately. If you visit a prison, you come to it, people in the prison will already know that you're there. So in this environment, all changes in rules about visits, about telephone calls, about parcels, about access to the outside world have an enormous potential and security factor as well. And I think we have to be conscious as well that it is in the interest of prison administration, detention administration, to ensure that this doesn't explode. And we have seen it exploding in countries like Italy or other places. So it is not only a public health issue, it's a security issue in and outside prisons. And it is, of course, a human rights issue, because in countries where there's a neglect or complacency to the health risks that are there, we have a human rights law issue in terms of accountability of states over ill treatment, torture, and maybe the right to life violations. So we have this complex of situations, but we deal with a state of emergency. We deal with a state of emergency in our societies more largely. But I think with the prison world itself, there's also a state of emergency. And one of the opportunities, and I get back to the opportunity factor, is many prison administrations typically feel left alone by the political side and by the political support. They are eager to find protection. They are eager to find responses. And that's an opportunity also for us to engage. I myself have seen this in my previous life, where I worked a lot on prison reforms in the former Soviet Union, where the fact that tuberculosis was rampant in the prisons opened up prison administration to work with you on prison and human rights reform. And I think we have a similar opportunity today. So I would say we have an urgency of the situation that has been described before. I fully endorse what my colleagues have said about how urgent it is to reduce prison population and to think about the right strategies there. Because if you ever visit prisons, social distancing, as we know, distancing as a concept is hardly workable in that context. But we also have to think about the opportunities of creating longer term changes in those systems using the situation we have now. And I take simple examples. If we have now, for example, electronic access of communication in a prison in Italy, why shouldn't that stay after the changes, after the post-COVID time? So we hope that it's also a facilitator to bring prisons and detention more into society and value more what is happening there. And I think you're all prove in a way, because you're interested in the issue, that it is an issue that deserves attention.
Thank you so very much. I think we're going to start with some questions, and maybe to set it up for those who are listening and watching who have never been to a prison or a jail or a detention center. Maybe the question goes to you, Scott, and Gerald mentioned the marketplace setup of some prisons outside of the United States. Scott, can you tell us a little bit about what do you mean? What does it look like? Tell us where people stay. Where do they shower? What kind of access do they have? What does a prison or a jail look like in the United States? And realizing that they don't all look the same. And how that helps facilitate the transmission of the virus.
Excellent question. And first, let me remind the audience that when we talk about congregate settings, there'll be some more familiar examples: cruise ships, nursing homes, college campuses, right? So that they all have that, a large group of people living in close quarters. I have to say, compared to that, even though there's a wide variety of physical layouts of jails and prisons and detention centers within the United States and certainly internationally, the one thing they all have in common is even closer quarters than those other community examples that I gave. Even though there are some segments of the population that are housed in single cells, quite often they are shared cells, and most often they're shared sections of the jail or prison with common eating areas, common shower and bathroom facilities, and a lot of trafficking by and near each other unavoidably. The recreation areas can be very small, passing through the halls and contact points. So understand that the housing can range from dormitory style housing where people are bunked and mere a few feet away from each other with even 50, 60, 70 people on one dormitory. This would obviously be a really high risk environment to transmit. But even, as I said, if they, when it's lights out, you go into cells of 1 or 2 inmates, you don't stay there for the 24 hours. So there's always these points in the routine where you're bringing the populations together in close quarters. Added to that, what we've already talked about, but must always return to, maintaining hygiene in these facilities is really difficult. I've learned a lot doing facility inspections over the last 20 years, especially with my environmental health colleagues who point out these facilities are not often well maintained. You have peeling paint, you have broken surfaces. You can't clean peeling paint. You can't clean countertops that are broken or split. So the poor maintenance of the facilities contributes to the fact that they're really hard to keep clean. And lastly, I'll point out that a lot of facilities have limitations on alcohol containing hand sanitizers and so forth because of security concerns. And even absent that, often don't have enough adequate access to simple things like soap. And we haven't even addressed really the issue of personal protective equipment, which is almost non-existent for inmates, even though people are thinking about it and talking about it now.
Speaking of personal protective equipment or PPE, we have a question from one of the attendees who said that he or she or they work with an organization trying to get PPE to healthcare organizations in high-risk populations and have called prisons to ask if they need PPE, but the response was that they did not need it. So how do you reconcile the fact that they were told that they don't need it in prisons or jails and the fact that you said that they don't exist and that they're necessary to help prevent the transmission of this virus? And Eunice, you can also, if you can answer that as well, that would be great.
Sure. Well, I think as we all know, there is a huge shortage of PPE in the country at this point in time. And the same is absolutely true for immigration detention facilities, prisons, and jails. It has taken court orders at some points to try to get these facilities to provide that equipment for detainees, and even in those circumstances has come up quite short. This is a very good question. I think there are justifications that facilities will have for accepting donations, even for things like books, and certainly for personal protective equipment. In that they are worried about the introduction of contraband, and for security reasons. I would think that in this particular context, it would behoove facilities to do the minimum, the required inspections to make sure that contraband is not being introduced to the facility, but really really also see the net good that would come from accepting these types of donations. One thing that got circulated was DHS very early on put a bid in for I think 45,000 masks at one point, and in light of the crisis and shortage, for medical professionals as well, I think there was a large critique of that, and certainly there are policy decisions that agencies like ICE could do to reduce population and reduce the risk absent and actually reduce this need for PPE in the facilities. Our concern is also that people who are in custody at this point, both in the prison, jail, and detention context, have all reported that, when they are provided with PPE, that it is not sufficient, that guards themselves are not wearing PPE properly or at all. And that is actually one of the larger concerns as well, because guards are the people who come in and out of the facility every day and have the autonomy to move throughout the facility, thus becoming more likely to be vectors in some sense. So, I think oftentimes this is a very localized question, and we would encourage people to continue to collect PPE, whether for medical professionals or for other types of facilities as well. That is absolutely a very vital service that you are providing at this time.
I wanted to, when we talk about COVID-19 and prisons and in general, I think we tend to think about the disease itself and how it affects the physical, the body and the physiology, but we forget that, of course, there are a lot of mental health implications of the disease in general. I see it in the public, in my own patients who are not incarcerated. So this is another question from the group, from the viewers, and how are you able to address the mental health implication that the virus introduces to the populations in these congregate facilities, and what is being done? And I know that Gerald has talked about it a little bit before when we prepped, so I'd like to give it to Scott first to talk about the US context, and then Gerald, if you could help us with the global picture.
So it's a really great question. We maybe don't, in the field we talk about it a lot, but maybe in the public forum, we do not discuss enough the impact of mental health in jails and prisons. And also, I can't comment on this without observing something we've observed for years, that in the United States, at least, jails and prisons have become sort of a default institution for people with undertreated or undiagnosed mental illness, that the largest institutions caring for those with chronic mental illness are jails and prisons. That's a failure of community health that is shameful. But I think you don't need to be an expert to understand that if you were, or you had a loved one, if you yourself or you're in the community and know someone who is either working or detained in one of these facilities, you would reasonably undergo appropriate anxiety and stress, significant stress about the safety. It's as if you've been informed that the building that someone is detained in is a fire trap, and the fire department has said it's not safe. But meanwhile, you don't see people moving with the appropriate urgency to try to protect or mitigate those risks. So the stress impact is really huge. The other thing we know about stress related to detention, as well with other high stress situations, the health impact of that stress will be lifelong. That even after the stress is removed, the adverse health effects, both mental health and even physical health impacts on heart disease, diabetes, hypertension, stroke, so forth, can be measured years out. So that is going to be sort of a second wave of cost of what we're doing.
Gerald, I'm wondering if you can give us a little bit of the picture of the how globally prisons and places of incarceration are addressing the mental health issues faced by prisoners who are detained during this time.
I think that probably in most parts of the world, the type of systems that you're talking about in the US don't exist. So I think that mental health or even physical health, whatever health issues in many parts of the world in the prison population are completely neglected. But if you imagine yourself being incarcerated in situations like I described in Togo, and it's not the worst country, it's actually a country that is quite willing to do human rights reforms to some extent, but where you would have 4,000 people in a place that maybe in a Western country would be populated by 500 or 300. You can imagine what already existing health and mental health issues must be there. Now, people are in dependency. They get information on a very selective basis. I think one of the lessons we have learned on a security side is it's absolutely vital that the authorities get support in communicating in a clear and calm manner about the crisis to the prison population. We have seen a number of prison riots, uprisings, mutinies in places where people got this anxiety, not knowing what was happening. You had an uprising in an Italian jail where they stormed the prison pharmacy, etc. So you see the explosive environment in which these prisons or detention centers find themselves. But we've also seen that there's need, and this as an anti-torture organization, we know, of course, that there are systems of psychosocial care that we put in place when we deal with torture victims, for example, for our staff as a principle. And in Tunisia, for example, our office has worked with an organization of psychologists. And for the first time, the prison administration was willing to let them into the prison to do psychosocial support to prison staff to deal with this crisis. So I think there are these type of openings, but of course you have to judge it within the availability of resources and thinking that exists in many parts of the world. And if I take the African example, but I could give you the same about Central America or about Asia, there is a total disregard for any health issue and certainly for mental health issue. But I think when we look at this crisis, we should look at how do we communicate in calm and transparent ways? How do we ensure that people know what is happening? How do we mitigate against some of the isolation people will feel? If a family visit is the only outside contact to life they have, if they care about their families, and this is the only way they get information, putting in place communication systems that they can speak to their families, that there is an information flow. You don't need a medical response, but you need a response that breaks this complete anxiety and isolation. And I think there's a lot that is done there in different countries. And I think that some of this might stay on afterwards.
I can tell you that we're getting a ton of questions, and I don't think we're going to be able to go through all of them, but here are a few more, and somewhat related, and this is for you, Eunice. One question is, do prisoners have any legal rights? And related to that, a question from Professor Anthony Fontes from American University, who's asking, have you observed any proactive responses or organization on the part of prisoners themselves to demand that they be provided with more effective protections? So prisoners' rights, prisoners' activity and advocacy for their own, for themselves and their peers.
Absolutely. And the answer to the question of whether or not prisoners and detainees have rights is absolutely yes. At least in the United States, the Constitution provides that under the 8th Amendment, there is a ban against cruel and unusual punishment. And the Supreme Court has held many times that to subject people to the risk of deadly communicable disease and not to mitigate those risks in an appropriate manner constitutes cruel and unusual punishment. And indeed, that is the basis for several court rulings around the country in finding that prison systems and immigration detention facilities have failed to meet their constitutional obligations in terms of protecting people in their custody. Once the government puts someone in their custody, they have the obligation to make sure that people are safe. And for the rights of civil pretrial detainees as well as immigrant detainees, remember, these are people who are in civil custody, not criminal custody. So they are actually entitled to a higher level of protection, which under the 5th Amendment and the 14th Amendment Due Process Clause, that states that, nothing about their conditions can even amount to looking like punishment. And to the extent that this threat of serious illness and death in the face of a lethal virus that has no cure, no vaccine, no treatment, certainly courts have agreed that that constitutes a clear due process violation. With respect to people who are currently incarcerated or detained and their attempts to argue for better treatment within the facility, better PPE, hygiene, social distancing, as well as release, this is of course happening. The question really is how much do we on the outside know about it, given the barriers that have been posed by facility officials. And, I can point to the fact that for example, at the Northwest Detention Center in Tacoma, Washington, detainees actually lined up with their bodies spelling SOS so that a helicopter above actually took a picture of that cry for help from within the detention center. We've had several letters, demands coming out from prisons, from detention centers, asking for all of these things, including, the bare minimum hygiene, equipment, training, and education, the end of transfers into facilities, right? I think that's another issue that has come up as a very, very problematic issue, is just the churn of people in and out from facility to facility. And indeed, we heard, for example, of cases at a detention facility in Pennsylvania, and we actually knew of several individuals at that detention facility that were then transferred down to a detention facility in Texas. And shortly thereafter, we also began to hear of confirmed cases at that facility. So we know that, ICE's refusal, for example, to stop transferring people between detention facilities actually making a bad situation even worse. These are all things that prisoners and detainees have clearly outlined for their own self-advocacy. And as Gerald had pointed to, sometimes, this self-advocacy has actually led to very repressive conditions and responses from officials, in the in the form of placing people in punitive solitary confinement, using tear gas to quell these types of requests. These are the types of, unfortunately, some of the responses that we're seeing to the demands and the requests by detainees and prisoners in light of this crisis.
I want to ask one last question that is being asked all the time, and we don't have much time left, but I'll give this question to Scott. Since we're all working, all of us, on trying to get people released, what constitutes safe release? How can you argue that people who have either been exposed or maybe are already have tested positive, how can we argue that they should be released into the community? How is it done safely?
It's a great question, and it sort of emphasizes maybe a point we started with, that your best opportunity is to disperse these populations early on. Many of us on this call may have received children coming back from college really early on, before outbreaks were associated with college and universities. That was one of the first sort of widespread moves that we saw in the closing of schools. Because in that case, you're likely releasing people who are not positive for the virus. It does get more complicated as things go on, and particularly if you have a facility that's already experiencing an outbreak. But it's still important to disperse the population from a public health and a individual risk point of view at that point. If you were to release someone into the community conceptually and you don't know their status, you do the same thing that we've done in other settings like that, where someone comes into a new environment who may or may not, hasn't been ruled out. If you can get them tested, that's ideal. But if you can't do that, sort of a self-quarantining for a 14-day period would be a reasonable measure to take. But if you think about the worst case scenario, if you're releasing someone who's asymptomatic positive, and if they do follow a reasonable self-quarantine, they might expose some household members. And I don't minimize the importance of that. But the alternative was that they were potentially going to expose hundreds, if not thousands of people that would in a center where there's churning, as we said, that rotating, that amplification effect through a community. So in public health, we're often making choices between a series of bad decisions and try to look at the one that poses the lowest risk to both individuals and the public.
Thank you so much. Unfortunately, we're almost out of time, and I wanted to thank each and every one of you and all the people who are watching and sending really amazing questions. I think what we're going to try to do is maybe collate all of these questions and address them separately, either in a future webinar or some educational initiatives or written materials. So we're also going to send some written materials related to with the ACLU, a link to the ACLU report and some other reports, including the reports about global prison that Gerald and his colleagues and us have put together. Thank you so much. I want to ask Donna McKay to come back and say a few parting words. And I thank everybody for listening. Thank you for your dedication. Thank you for everybody working on medical legal collaborations. This is certainly a future of collaboration between disciplines and professions. And hopefully this will be sustained for the long run. And Donna, please take it from there.
Thanks, Dr. Mishori. And I want to thank you for organizing this panel and for moderating it. There were so many questions that came up, and we unfortunately couldn't answer them all, but it really showed an engaged group of advocates, and that's very exciting for us. And so I thank our panelists, and I really appreciated the hopefulness that we heard a lot of examples of stories of what is working. As Gerald said, there are opportunities to be found here, and so many of our colleagues in the advocacy community are seizing them and doing such important work. So if we get this right during this really critical time, we're encouraging humane and smart responses now, but we're informing for decision-making for the future. So as Dr. Mishori just said, I think that also today's discussion really helped to show us how just the important intersection of medicine and law and the power that it can have when we combine those and also bring a healthy dose of activism. So, so thank you to all on the call and the Zoom who are a part of that activism, and please check out PHR's website. There are a number of actions that you can take, and we really appreciate you participating and being partners in this work. And we hope to see you next week at our next webinar series. Thank you.